Welcome to the deep dive. Today we're taking on a field whose history is, well, arguably the most dramatic and life-altering in all of medicine.
That's right.
The history of surgery. Our goal here is to really get that comprehensive, structured understanding of its evolution. Tracking how these key innovators systematically overcame obstacles that, frankly, defined human suffering for millennia.
It really is a story of paradigm shifts. And often it's about single individuals who somehow managed to see beyond the dogma that everyone else accepted.
Yeah.
Surgery's history isn't this smooth, straight line. It's more like plateaus, right? Each one ending in a really revolutionary advance. And it's been accelerating like crazy over the last century or so, transforming these pragmatic, sometimes brutal interventions into, well, precision science.
And when you dig into that transformation, the whole narrative seems to hinge on overcoming these two massive, seemingly insurmountable obstacles. They plagued surgery for thousands of years. Our sources actually call them the twin problems. First, there's the sheer, unimaginable agony of the knife. Just awful.
Unthinkable today.
And second, the almost guaranteed inevitability of wound infection or sepsis.
Yeah, those two barriers basically made any kind of internal surgery a death sentence. And to really grasp the scale of the revolution, you have to realize that the fundamental fix for both the pain problem and the infection problem happened in this incredibly short period.
It's shocking how short.
Just 21 years, between 1846 and 1867. Before that window, surgery was, well, archaic is the word. After it, the path to modernity was suddenly clear.
Understanding the context, both before and after that pivot point, it feels essential. It helps explain not just what changed, but maybe why it took so long.
Yeah.
And, how institutional inertia works.
Exactly. That resistance to change is a huge part of the story. We're going to trace the whole journey starting right back with the earliest functional trauma care and bring it right up to modern transplantation.
Okay, let's unpack this. Starting with those very first surgeons, the ones lost to time, and the surprisingly sophisticated, yet fundamentally limited skills they actually mastered.
Right. If we try to go way back to the earliest practitioners, those whose names are long gone, their expertise was rooted entirely in emergency pragmatism. We're talking about the real basics of emergency care.
Like what specifically?
Knowing how to bind up a bleeding wound, how to splint a broken bone properly, how to safely drain an abscess, a collection of pus. These were pretty much the boundaries of successful life-saving intervention back then.
And the evidence that these skills were developed independently and effectively, it comes from some pretty remarkable accounts documented much, much later, mostly by 19th and early 20th century explorers, medical missionaries too.
Yeah, these folks ventured into really isolated communities, places like the Atlas Mountains in North Africa, or deep in the jungles of Central Africa, villages in Borneo, places where people had basically never encountered Western medicine.
And they saw complex procedures being done.
They did. Procedures that showed real skill, performed by people completely cut off from the developments happening elsewhere. It really underscores this idea that surgical knowledge, at its core, is a practical skill. It's learned, based on watching what works, what doesn't.
It's empirical almost.
Absolutely. And a fascinating, specific example of this kind of ancient knowledge found pretty much globally is trephination of the skull.
That's drilling a hole in the head, right? Sounds terrifying.
It is. Drilling or scraping a hole into the skull. It was practiced across huge distances, different eras. Why? Probably to relieve pressure, maybe treat chronic headaches, or perhaps even for, ritualistic purposes. We don't always know the exact reason.
But even with that level of sophistication, the guiding principle was still this pragmatism of survival. Early surgeons were effective where the body's own healing could sort of take over, but they knew their limits. They had a very clear line they couldn't cross.
Precisely. If a wound involved major organs, the brain, the lungs, the guts, anything in the abdomen, or if a major artery was cut clean through, they knew. Through probably very painful experience, they knew the patient was almost certainly going to die.
So the pragmatic choice was often do nothing.
Often, yes. To leave those kinds of wounds largely untouched, because interfering might just make things worse or hasten death. Fracture management, though, that was often successful because it was conservative. Straighten the limb, splint it securely, immobilize it, and just wait for nature to do its thing for clinical union.
This brings us to something really interesting, a historical misconception that actually had this huge kind of inertial effect on accepting antisepsis much, much later, the whole idea of pus.
Ah, yes, laudable pusses. For centuries, the appearance of that thick, creamy stuff coming out of a wound was actually seen as a good sign.
Laudable, meaning praiseworthy.
Exactly, praiseworthy pus. The belief was the body was successfully fighting back, mounting a defense. The pus was seen as the physical proof that the illness, the bad humors maybe, were being pushed out.
And this was contrasted with what?
With spreading gangrene, that produced a dark, foul-smelling discharge, and it universally meant the patient was doomed, impending death. So you see the logic. Creamy pus? Good. Stinking decay? Bad.
What's crucial for us to understand then is that if pus was laudable, if it was seen as good, then the whole concept of infection being caused by something invisible coming from the outside was just impossible to grasp.
Completely impossible. That means for generations, surgeons were literally looking at massive bacterial load at sepsis and interpreting it as the body succeeding, which made them totally blind to the idea that the contamination of the wound itself was the actual problem.
Wow. Okay, so beyond trauma care, we also see ancient surgery moving into specific planned procedures. You mentioned circumcision earlier.
Right. Ancient circumcision is confirmed by, for instance, a drawing found in Memphis in ancient Egypt, dated way back, maybe 3000 to 2400 BCE. It was clearly widespread, but it seems to have been primarily ritualistic, not really therapeutic in the way we think of it.
Then there was something much more dangerous, clearly therapeutic though, lithotomy, cutting for the stone.
Extremely painful, extremely dangerous. This was usually a perineal approach, cutting near the base of the body to remove vesical calculi, bladder stones. And it was performed by ancient Hindu surgeons, Greek, Roman, Arab surgeons. It was known across the ancient world.
And there's a detail here that raises a kind of historical flag, isn't there?
Yeah.
About who was getting these stones.
Yes. The sources confirm this was a common disease they treated specifically in children. Now, bladder stones today in developed countries, they're pretty rare in children. This strongly suggests that the high prevalence back then was tied to something environmental, or maybe more likely, severe dietary deficiencies that led to this calculus disease. It's a pathology in that historical context that we don't fully understand. Why so many kids?
Okay, let's circle back to the skill levels sometimes found in these isolated communities.
Hmm.
That remarkable account from 1884. Robert Felkin, an MD.
Ah, yes. Felkin's observation in Uganda, it's extraordinary. He witnessed and meticulously recorded, even drew, what he described as a classical Caesarean section.
And there's something about banana wine.
Right. Before the procedure, the patient was intoxicated with banana wine. Now, this wasn't anesthesia as we know it, obviously, but it was a form of sedation, a way to manage the pain and terror, and likely provided some crude antiseptic effect because of the alcohol content.
But the amazing part was the outcome.
The truly amazing part. Felkin recorded that the surgeon successfully closed the uterus afterwards, and when Felkin left, 11 days later, both the mother and the child were alive and well. You have to compare that to European hospitals at the time.
Where C-section mortality was sky high.
Near 100%, especially if the operation involved opening the uterus. Death from peritonitis from sepsis was almost guaranteed. This Ugandan tradition somehow had figured out how to overcome the infection problem, at least locally. It's a powerful reminder that life-saving surgical ingenuity wasn't just a Western thing.
Okay, so if the ancient world was dealing with the slow burn of infection, European surgery then plunged into this acute crisis starting around the 14th century, and it was all down to military technology.
Precisely. The introduction of gunpowder and firearms into European warfare just fundamentally radically changed the types of wounds surgeons were seeing.
And we could even pinpoint this change.
Pretty much. Gunpowder was first used significantly, sources say, at the Battle of Crécy in 1346. Edward III's English forces against Philip VI of France. Suddenly, surgeons weren't just dealing with relatively clean sword cuts or simple fractures anymore.
Now, they were facing musket balls, cannon shot. Explain why that type of injury was so much more devastating than, say, a stab wound.
Well, a projectile, like a musket ball, causes immense blunt trauma. It doesn't just cut, it smashes and tears tissue. It drives contaminated material, bits of clothing, dirt, foreign debris deep into the wound track. And crucially, it causes gross tissue damage that destroys the local blood supply.
Necrosis, right? Tissue death.
Exactly. Necrosis. And this dead tissue, starved of oxygen because the blood supply is gone, creates the perfect low oxygen environment, anaerobic conditions for really lethal bacteria to thrive, specifically the ones causing tetanus and gas gangrene.
Ah, okay. So Wounds that might have been survivable before suddenly became almost universally fatal because of these specific bacteria.
That's the key. The nature of the injury itself created the perfect storm for these horrific infections.
And this leads directly to that misguided cure.
Mm,
Because these new wounds were so deadly, the assumption, the logical leap they made, was that the gunpowder itself must be poisonous.
exactly. I mean, it seemed logical, right? New weapon, new type of death must be the powder. So if the powder is poison, what do? You have to destroy the poison, burn it out?
Hence the cautery or boiling oil.
Right. The standard remedy became cautery with red-hot irons or pouring boiling oil directly into the wound. And this awful practice wasn't just random, it was heavily codified. It got popularized because it was recommended in this hugely influential textbook by an Italian surgeon, Giovanni da Vigo. His book went through something like 40 editions. It was the surgical standard across Europe for centuries.
It's devastating to think about. The
Yeah.
treatment was actually worse than the disease.
Oh, far worse. It was a horrific cycle. By pouring boiling oil or using red-hot cautery, they were inflicting more severe trauma, causing more necrosis, more dead tissue.
Which just made the anaerobic conditions even better for the bacteria.
Precisely. This additional dead tissue further lowered the oxygen levels in the wound bed, actually enhancing the anaerobic environment. It made the subsequent tetanus or gas gangrene infections even more certain, even more severe. They were basically treating a bacterial problem with an extreme physical trauma that guaranteed the bacteria would flourish.
Okay, this nightmare scenario sets the stage perfectly for one of the great pivot points in early surgical history. Ambroise Paré, a French military surgeon trained at the Hôtel Dieu in Paris. His big moment came during a campaign in Turin, 1537.
Right, Pere. He was right there on the battlefield dealing with these horrific gunshot wounds day in, day out. And the famous story, the turning point, it wasn't some stroke of genius insight initially. It was simple supply chain failure combined with critical observation.
He ran out of boiling oil.
He ran out of boiling oil. He had a barn full of seriously wounded soldiers. He treated as many as he could the standard, agonizing way, but then the oil was gone. So, forced by necessity for the rest of his patients, he just used a simple dressing. It was apparently a mixture of egg yolk, oil of roses, and turpentine. Nothing fancy.
So essentially, completely by accident, he ran the first documented randomized controlled trial in surgical history.
That is the perfect way to put it.
Yeah.
You had two groups of patients treated at the same time, same conditions, just one variable different. Boiling oil versus simple dressing. And the next morning, the difference was stark, immediate, palpable.
What did he see?
His treated group, the ones who'd had the boiling oil, they were in absolute agony, feverish, their wounds inflamed, immense suffering. His controls, the ones with the simple, soothing dressing, they were resting comfortably, their wounds looked calmer. The contrast was undeniable.
And that observation led to his famous resolution.
Yes, he wrote something like, "I resolved never again to so cruelly burden the poor wounded by gunshot." It was this profound rejection of maybe 200 years of established authoritative dogma based purely on direct empirical patient evidence. Seeing was believing.
And Paré's scientific pivot, this move towards observation, it didn't stop just with wound management, did it?
No, his second major advance tackled the other huge surgical problem, bleeding, hemorrhage. He demonstrated that bleeding from major blood vessels should be treated by simply tying off the divided vessel ends with thread ligation.
Instead of the standard practice.
Which was, again, cautery, sealing the bleeding artery with a red-hot iron, agonizing, and it caused significant tissue damage. Ligation was cleaner, allowed for better healing, and avoided the systemic shock caused by extreme burning. Paré fundamentally shifted the whole concept of surgical practice away from just following ancient texts towards rational observation and, well, gentler technique.
So despite Paré's brilliant advances improving wound care, controlling bleeding, the profession still remained fundamentally stuck for the next 3 centuries, still facing those twin problems, especially the first one, pain.
Oh, absolutely. You have to try and picture an operation back then. The surgeon trying to be quick, precise maybe, while the patient is screaming, thrashing, physically held down by strong assistants.
It sounds like a scene from hell.
It was a spectacle of terror, honestly. Before the mid-19th century, any attempts to lessen the pain were just largely ineffective. They'd use massive doses of opium or huge amounts of alcohol, maybe laudanum, which is an opium tincture. These might sometimes dull the consciousness a bit, but they rarely, if ever, eliminated the excruciating awareness of the knife.
Which meant speed was everything.
Speed was the surgeon's only mercy. Surgeons like Robert Liston in London became famous for their incredible speed. Amputations completed in under 3 minutes, sometimes even faster. But this wasn't just surgical showmanship, it was a brutal necessity, born purely from the need to minimize the duration of unbearable suffering.
Okay, so the great breakthrough, the inhalation revolution that finally conquered pain, it didn't actually come from the surgical establishment itself, did it?
No, interestingly, it came from dentistry, and this is where it gets really fascinating. The solution to this age-old agony problem was discovered, or at least popularized, by William Morton, a dentist in Boston. And the agent was ether.
Ether, like the chemical.
Exactly, diethyl ether. Morton had been experimenting with it for pulling teeth for dental extractions. But making the leap from pulling a tooth to major surgery, that needed a big public validation. And that crucial landmark moment happened on October 16th, 1846.
What happened that day?
Morton administered the ether vapor. The operation itself, removing a small benign lump from a patient's neck, was performed by John Warren, who was the senior surgeon at the very prestigious Massachusetts General Hospital.
And this took place in the famous Ether Dome.
That's right, in the hospital's surgical amphitheater, now known as the Ether Dome. The patient, a man named Gilbert Abbott, was put under. Warren removed the tuner, and when Abbott woke up, he famously said, "Gentlemen, this is no humbug." Or maybe it was, "I felt no pain." Accounts vary slightly, but the message was clear.
It worked. It actually worked.
It proved the concept. But, removing a neck lump is one thing. The ultimate test was major surgery.
Like an amputation.
Exactly. And that test came just 3 weeks later. Same surgeon, John Warren. He successfully performed a completely painless above-knee amputation on a 21-year-old servant girl named Fanny Burton using Morton's ether anesthesia. The implications were just staggering. Overnight, the surgeon gained the luxury of time, precision, carefulness. The first great barrier to modern surgery had just collapsed.
And the speed of adoption here is just astonishing, especially when you think about communication back then in the 1840s. News traveled literally by coach and by sailing ship.
Yet the adoption was virtually instantaneous, because the problem of pain wasn't controversial. It was universally acknowledged, universally suffered, and surgeons were desperate for a solution. The demand was absolute.
So news spread, and surgeons everywhere started copying it.
Within months, surgeons all over the world were building or copying Morton's simple inhaler apparatus. In London, a dentist named James Robinson gave ether on December 19th, 1846. Just 2 days after that, Robert Liston, the famously fast surgeon we mentioned, carried out a successful and painless above-knee amputation at University College Hospital. He apparently turned to the observers and said, "This Yankee dodge, gentlemen, beats mesmerism hollow."
A Yankee dodge. But ether, while revolutionary, it wasn't perfect, right? It had drawbacks.
Immediate recognized drawbacks. Induction could be slow and unpleasant. Patients often struggled during it. It had a pungent, unpleasant smell. And frequently, patients suffered from significant postoperative nausea and vomiting. This created a clear need for something better, a refinement.
And that refinement came from Scotland.
Yes, from James Young Simpson. He was the professor of obstetrics in Edinburgh, a really dynamic figure.
And he was looking for an alternative.
Simpson was already using ether in his obstetrics practice by January 1847, helping women during childbirth. But he noted its disadvantages and was determined to find something superior. He began methodically experimenting with various volatile organic liquids, inhaling them himself, apparently often with friends after dinner parties.
Got risky.
Very risky. Until, in November 1847, he and his colleagues tried chloroform, and they basically all passed out, waking up later under the table. But Simpson realized it worked.
And chloroform had advantages over ether.
Significant advantages. It had a pleasant, sweet smell. Induction was much easier, much quicker, and it seemed to have fewer lingering after effects, like vomiting.
Now, chloroform's acceptance got a huge boost from a very prominent patient.
The highest possible endorsement. There was still considerable skepticism, especially moral and religious objections about relieving pain, particularly for women during childbirth. Many felt it went against biblical injunctions.
But that changed.
That skepticism largely evaporated when Dr. John Snow successfully administered chloroform to Queen Victoria herself during the birth of Prince Leopold, her 8th child, in 1851.
And the Queen's reaction.
She declared herself delighted. She called it that blessed chloroform. This royal stamp of approval was a massive cultural and medical moment. It effectively legitimized pain relief in childbirth and further cemented the practice of anesthesia globally. The new specialty of anesthesia was instantly born, fully adopted. The need for agonizing speed vanished, and the entire internal landscape of the human body was suddenly, finally, open for careful surgical exploration.
Okay, so pain is conquered almost overnight. But the contrast here with the second barrier, infection, is one of the most important takeaways for understanding how medicine actually changes, isn't it?
It's incredibly telling. While anesthesia was accepted instantly, welcomed with open arms, the acceptance of antisepsis, the fight against infection, was painfully, agonizingly slow.
Why? Why did the surgical community resist the solution to infection so fiercely? Especially when the death rates were so appalling and the data started to emerge.
Well, I think it goes back to what we discussed earlier. The problem of pain was macroscopically obvious. Everyone could see it, hear it, feel the terror. But the problem of infection, that was tied to an invisible theoretical cause, these microorganisms. And remember, laudable pus.
Right, the idea that pus was good, a sign of healing.
Exactly. Most surgeons genuinely accepted suppuration, pus formation, as a normal, even necessary part of the healing process. So, to accept the ideas of someone like Lister, they had to throw out centuries of deeply ingrained clinical belief, their own observations filtered through that old lens. It required a massive mental shift.
So the breakthrough that Joseph Lister eventually leveraged, it had to come from outside surgery altogether, from chemistry and microbiology.
Absolutely. Specifically from the groundbreaking work of Louis Pasteur in Paris. Pasteur wasn't a medical doctor, he's a chemist.
And he was working on fermentation, spoilage, that kind of thing.
Right. Things like why milk went sour, why wine spoiled, why broth putrefied. Using brilliant, simple experiments like his famous ones with swan neck flasks that allowed air in but trapped dust particles. Pasteur proved that this decay wasn't caused by spontaneous generation or just by exposure to air itself.
It was caused by living things in the air.
Tiny, living microorganisms present in the air, on dust, everywhere. He provided the definitive proof that germs existed and were the active agents of decomposition and fermentation.
And how did this chemical knowledge get to Lister, the surgeon in Glasgow?
Through academic networking, essentially. The professor of chemistry at the University of Glasgow, a man named Thomas Anderson, knew about Pasteur's work. It was being published in French chemistry journals, not medical ones. Anderson drew Lister's attention to these findings.
Lister being the professor of surgery at Glasgow.
Correct. And Lister was intensely troubled by the horrific death rates in his surgical wards. They were appalling, even by the standards of the day. When he read Pasteur, he had this immediate aha moment. He connected Pasteur's findings on food spoilage directly to wound sepsis, to surgical infection.
He realized the pus wasn't laudable at all. It was putrefaction.
Exactly. He realized that the air itself wasn't the problem, nor was the wound spontaneously generating poison. It was invisible microorganisms carried in the air or on instruments or the surgeon's hands or the dressings that were contaminating the wound and causing the sepsis, the decay.
Okay, so if germs are the enemy, the question becomes, how do you kill them in a living patient? You can't boil the patient, which was Pasteur's method for sterilizing broth.
Right. Boiling was out. Lister needed a chemical agent, a germicide, and his choice was crude carbolic acid, which is also known as phenol.
Why carbolic acid specifically?
It seems quite practical, actually. He'd heard reports that carbolic acid was being used successfully to treat, or at least deodorize, the foul-smelling sewage effluent from the stinking drains of the city of Carlisle.
And that smell reminded him of his hospital wards.
He explicitly noted the resemblance, that pervasive, sickening stench of his surgical wards at the Glasgow Royal Infirmary, the smell of sepsis, of death, reminded him of Carlisle's drains. So he thought, if carbolic acid cleans up sewage, maybe it can clean up wounds. It was an inspired, if slightly grim, connection.
This leads us to the crucial experiment, the real genesis moment of modern safe surgery. August 12, 1867.
That's the date. The patient was an 11-year-old boy, James Greenlees. He'd suffered a severe compound fracture of his tibia, the shin bone broken clean through the skin after being run over by a wagon.
And the prognosis for that in 1867, without Lister's intervention.
Dire, near universal infection. Amputation was common, and even then mortality was incredibly high, maybe a 40–50% chance of dying. It was a potentially lethal injury.
So what did Lister do?
He meticulously cleaned the wound, removing dirt and debris. Then he applied crude carbolic acid directly onto the wound surfaces. He also soaked his dressings pieces of gauze in the carbolic acid solution. Then he splinted and immobilized the leg as usual. The key difference was the chemical attack on the microbes.
And the results.
Immediate and dramatic. After 4 days, when Lister changed the dressing, he noted there was no smell, no stench of decay, none of the familiar signs of hospital gangrene or severe infection. There wasn't even any laudable pus.
Wow. And the boy.
6 weeks later, the boy walked out of the hospital. His fracture healed without any significant infection.
And Lister documented this, comparing it to previous outcomes.
Yes, he knew the baseline. Before his carbolic acid regime, compound fractures in his wards had, as we said, basically a universal infection rate and that terrifying 46% mortality rate. His initial small series of 11 compound fracture patients treated with carbolic acid showed staggering success. It was powerful proof. Kill the microscopic life, save the patient's life and limb.
This success must have fundamentally changed what surgery was even possible.
It absolutely did. Lister soon felt confident enough to attempt procedures that would have been considered absolute malpractice just months before. For instance, deliberately operating on non-united fractures bones that hadn't healed properly, like the kneecap, patella, or the point of the elbow, olecranon.
Why was that malpractice before?
Because to operate on a closed fracture, one where the skin wasn't broken, you had to make it an open fracture. You had to cut the skin, expose the bone to the air, to the hospital environment. And before Lister, doing that guaranteed it would become infected, just like a compound fracture. It guaranteed suppuration and often led to amputation or death.
But antisepsis changed the risk completely.
Entirely. Suddenly, surgeons could carefully manipulate the body's deep structures, confident they had a way to mitigate, if not eliminate, the microbial threat. The door to internal surgery creaked open.
But despite this phenomenal success, this clear data, adoption was slow. It wasn't like anesthesia.
Not at all. It took maybe 2 decades for Lister's principles to be widely accepted and properly implemented. It faced enormous resistance.
Why such resistance? We mentioned the laudable puss's dogma.
That was a huge part of it. It required abandoning that deeply held belief. Also, many surgeons just viewed carbolic acid as another topical treatment, another medicament, maybe an irritant one at that. They failed to grasp the real significance, the underlying microbial theory. They didn't internalize the totally novel attitude required.
Which was?
That they, the surgeons themselves, their hands, their unsterilized instruments, their coats, were potentially carrying unseen death into the wounds of their patients. It was a humbling, revolutionary concept. Plus, Lister's early methods, like the carbolic spray used to try and sterilize the air in the operating room, were cumbersome and unpleasant for the surgical team.
So the initial phase, Listerism, which was antisepsis killing germs, already present at the wing site that gradually evolved.
It evolved into asepsis. The idea shifted from killing germs in the wound to preventing them from getting there in the first place.
And this shift happened mainly elsewhere.
Primarily driven by surgeons in Germany, actually, over the next couple of decades, asepsis involved total environmental control.
What did that mean in practice?
It meant sterilizing everything that might come near the patient. Instruments, dressings, surgical drapes, all subjected to high-pressure steam heat in autoclaves to kill all microbes. Surgeons began wearing sterile masks, caps, and gowns to prevent shedding bacteria from their own bodies into the surgical field.
And the final piece of that environmental puzzle, the direct barrier between the surgeon's hand and the patient.
That came with the routine use of sterile rubber gloves. While others had experimented, it was William Halsted, a brilliant and innovative surgeon at Johns Hopkins in Baltimore, who really popularized their use around 1889. Apparently, initially it was to protect his scrub nurses' hands from the harsh chemicals, but the benefit in preventing infection quickly became obvious.
So by the end of the 19th century,
the operating theater environment had completely transformed. Gone was the old lecture hall with surgeons in street clothes. Now you had the clean, controlled, sterile operating room that we essentially recognize today. This aseptic environment was the absolutely essential foundation for all the complex internal surgery that was about to explode in the 20th century.
right, so pain is gone, infection is largely contained or at least manageable through asepsis. The surgeon now has safe access. They can go inside the major body cavities. And this is the moment, isn't it, where modern surgical specialization just takes off. Surgeons start pushing the boundaries into the abdomen, the chest, the heart, eventually the brain.
Exactly. The abdomen was really the first major frontier to be conquered after asepsis became reliable. Remember before this, penetrating abdominal wounds, or any operation that involved opening the peritoneum, the lining of the abdomen, was almost universally fatal because of peritonitis overwhelming sepsis.
But now the ability to operate safely inside the abdomen meant surgeons could start treating internal diseases, not just trauma, especially things like cancer.
Correct. And one of the true pioneers who proved that major resection, cutting out large parts of internal organs, was actually possible was Theodor Billroth, a German surgeon working in Vienna. In 1881, he successfully performed the first partial gastrectomy for cancer of the pylorus, the outlet of the stomach.
That sounds incredibly difficult for the time.
Immense technical challenge. It wasn't just about removing the cancerous part of the stomach. The really hard part was reestablishing the connection, creating a safe anastomosis, a join between the remaining stomach and the small intestine.
Because if that joint leaked,
Instant fatal peritonitis. Bill Roth's success proved that these complex reconstructions could be done reliably using the new aseptic techniques. It really paved the way for all subsequent gastrointestinal surgery.
and building on that success, even more complex cancer procedures started to emerge, tackling tumors that were previously just completely inoperable.
Yes. For example, Ernest Miles, working at the Royal Cancer Hospital in London, now the Royal Marsden. In 1907, he performed the first successful abdominoperineal resection for a rectal carcinoma.
Explain what that involves. It sounds major.
It is a monumental operation. The Miles procedure involves operating simultaneously in two very complex anatomical fields, through the abdomen from above and through the perineum, the area between the legs, from below. The goal is to completely remove the entire rectum and anus, usually for low-lying rectal cancers. Often, this leaves the patient with a permanent colostomy, an opening on the abdomen for waste.
And success in that operation really showed.
It demonstrated absolute mastery over several critical challenges: controlling major hemorrhage in deep, difficult spaces, managing surgical shock, and, critically, preventing infection in these deep, multi-cavity wounds. It was proof of how far technique and asepsis had come.
Okay, moving from the abdomen, let's talk about the brain. Neurosurgery, an incredibly delicate field.
And one largely defined by the work of Harvey Cushing, an American surgeon working primarily in Boston. Cushing is rightly credited with laying down the fundamental principles of modern neurosurgery.
What was his particular genius? Technique?
Meticulous, painstaking technique, absolutely, but also a deep understanding of physiology. Before Cushing, brain surgery, when attempted, was often associated with torrential, uncontrollable blood loss, which frequently killed the patient on the table. Cushing emphasized extreme hemostasis, perfect control of every tiny bleeding vessel, often using silver clips he developed. He advocated gradual, minimal trauma dissection and careful preservation of delicate brain tissue.
So he turned it from a gamble into a discipline.
He turned brain surgery from a desperate, often rapidly fatal procedure into a systematic, controlled, and increasingly successful discipline. His results were dramatically better than anyone before him.
And we also need to acknowledge Theodor Kocher, working in Bernay, Switzerland. He essentially established thyroid surgery as a safe specialty, and he holds a very rare distinction for a surgeon.
Yes, Kocher is one of the very few surgeons ever awarded the Nobel Prize in Physiology or Medicine back in 1909.
And his Nobel wasn't just for surgical skill.
No, it recognized profound scientific advancement derived from his surgical work. Thyroid surgery, operating on the thyroid gland in the neck, had historically been incredibly hazardous. The gland is very vascular, bleeds easily, and it's surrounded by vital structures. The parathyroid gland is crucial for calcium metabolism, and the recurrent laryngeal nerves controlling the vocal cords. Damaging them was common and devastating.
So what did Kocher do?
Kocher meticulously studied the anatomy, developed specific techniques to identify and preserve those vital structures, and systematized the entire approach to thyroidectomy. He reduced the mortality rate for the procedure from over 10%, maybe even higher, down to less than 1%. He transformed a high-risk, often fatal operation into a standard, safe, curative practice for conditions like goiter. His work perfectly showcased how detailed anatomical knowledge and perfected technique applied under aseptic conditions could radically improve outcomes for endocrine diseases.
Okay, so we've moved from the early 20th century pioneers like Bill Roth, Cushing, Kocher. As we head deeper into the 20th century and towards the present day, the pace of change, as you said earlier, it becomes an almost geometrical progression. It just explodes.
It really does. The foundation laid by anesthesia and asepsis basically allowed science and technology from many different fields to become the driving engine of surgical innovation.
And This progression happened on multiple fronts, right? Chemical advances, mechanical ones.
Absolutely. Chemically, arguably the single greatest post-Listerian revolution, the thing that provided another huge safety net, was the arrival of antibiotics, heralded, of course, by the isolation of penicillin by Alexander Fleming, but really made clinically usable by the team led by Lord Howard Florey and Ernst Chain at Oxford during World War II.
And penicillin didn't just help with post-operative infections, did it? It changed who could even have surgery.
That's a crucial point. Antibiotics transform the management of pre-existing sepsis. Think about a patient coming in with a severe, potentially fatal infection already raging, like osteomyelitis, a deep bone infection, or widespread peritonitis from a burst appendix. Previously, surgery might have been impossible or guaranteed to fail, but antibiotics suddenly offered a way to control the systemic infection, to get the patient stable enough for surgery, or to manage infection alongside the operation. They acted as this powerful systemic defense, backing up the local defenses provided by aseptic technique in the OR.
Okay, so that's the chemical side. What about mechanical leaps? Repairing and replacing body parts.
Orthopedics saw enormous advances, particularly joint replacement surgery. This has just dramatically improved the quality of life for millions and millions of people suffering from crippling arthritis. And much of the credit for perfecting modern joint replacement, especially for the hip, goes to Sir John Charnley, working in Wrightington near Manchester.
Charnley's innovation wasn't just the idea of replacing a joint, was it? It was about the details.
Meticulous attention to detail and engineering principles. He pioneered the concept of low-friction arthroplasty for the hip, using a small stainless steel femoral head articulating against a socket made of high-density polyethylene. This combination minimized friction and wear. He also developed specialized acrylic bone cement for securely fixing the implants to the patient's bone.
And he also took asepsis to another level, didn't he?
He did. Charnley realized that even minuscule levels of bacterial contamination during the long hip replacement operation could lead to devastating deep infections around the implant much later. So he developed specialized ultra-clean air operating theaters, sometimes called enclosures or body exhaust suits for the surgical team, specifically designed to minimize the number of airborne bacteria settling onto the exposed joint surfaces during the procedure. This was taking aseptic principles to a hyper-modern, almost industrial level of control.
Alongside replacing parts, we also saw the rise of doing surgery without big cuts. Minimal access surgery.
Right. The ability to perform complex procedures inside the body through tiny incisions, using cameras and long instruments. This revolution was entirely dependent on technological breakthroughs happening completely outside of medicine. Specifically, the development and introduction of practical fiber optics. A huge amount of credit here goes to Harold Hopkins, who was a professor of applied optics at the University of Reading in the UK.
How did fiber optics change surgery?
Hopkins' work on coherent fiber bundles allowed the transmission of high-quality images through thin, flexible glass fibers. This meant surgeons could insert these tiny, rigid, or flexible tubes endoscopes equipped with bright illumination and high-resolution miniature cameras directly into body cavities or joints.
Seeing inside without cutting open.
Exactly. This absolutely revolutionized procedures like gallbladder removal, laparoscopic cholecystectomy became the gold standard, appendectomy, knee surgery, arthroscopy, and countless others. It drastically reduced surgical trauma, postoperative pain, hospital stays, and recovery time. A massive shift driven by physics and optics.
Okay, finally, we arrive at what many would consider the most complex, most dazzling triumph of modern surgery: organ transplantation.
Yes, transplanting organs like kidneys, livers, hearts, lungs. It's arguably the pinnacle. Now, the surgical technique itself, physically plumbing a new organ into the recipient's body, connecting the blood vessels and ducts, that's incredibly demanding, highly skilled work. But the truly critical hurdle, the biological barrier that defined the success or failure of transplantation for decades, was immunological rejection.
The body recognizing the new organ as foreign and attacking it.
Precisely. Preventing or controlling that rejection response was the key. And this brings us to the vital work on immunosuppression, particularly by Sir Roy Callaney, a surgeon and researcher primarily based in Cambridge. His work in developing effective immunosuppressive drugs was absolutely foundational for the entire field.
He worked on several key drugs over the years.
His timeline of developing these drugs really tracks the history of successful transplantation. He first demonstrated the potential of 6-mercaptopurine, 6-MP, back in 1960. Then he quickly moved on to azathioprine, Imuron, in 1961, which was a more effective and slightly less toxic derivative of 6-MP. Azathioprine became the cornerstone of immunosuppression for the first couple of decades of kidney transplantation, significantly dampening the T-cell-mediated rejection response.
But the real game-changer drug, the one that made heart and liver transplantation truly viable and routine, came later.
That was cephalosporin. Isolated from a soil fungus, its powerful immunosuppressive effects were recognized, and Colony was instrumental in bringing it into clinical transplantation starting around 1976-1978.
And cyclosporine was different.
It offered a significantly more specific way to suppress the immune system, targeting T cells more directly, and it was generally less broadly toxic than the earlier drugs like azathioprine combined with steroids. This dramatically improved long-term graft survival rates, especially for organs more challenging than kidneys, like livers and hearts. These three chemical advancements, really 6-MP, azathioprine, and then the breakthrough with cyclosporine, they weren't surgical tools per se, but they were the essential pharmacological keys that unlocked the entire potential of modern organ transplantation surgery.
It's incredible. The journey from just binding a simple surface wound, maybe 3000 BCE, to successfully replacing a failing liver or heart in the late 20th century. It really is a testament to the power of cross-disciplinary science and relentless innovation. Hashtag tag outro.
It truly is.
So we've tracked this incredible arc, starting with those pragmatic, essential survival skills back in antiquity, moving through that accidental yet crucial scientific pivot made by Ambroise Paré, and then seeing how everything hinged on that incredibly compressed period, just 21 years between 1846 and 1867, where first pain and then infection were finally conquered.
And I think for you, the listener seeking genuine mastery of this field, understanding the context of how these changes happen is absolutely vital. The greatest leaps, as we've seen, weren't always fueled just by the surgeon's dexterity with a knife. They came from basic science, from careful observation, from critical thinking that challenged dogma.
Yeah.
Whether that was Paré running his accidental controlled trial with wound dressings, or Pasteur's chemistry proving the existence of the unseen microbial world, or Lister making that connection between the stench of his hospital wards and the stench of city drains. It's that application of observation and science that drove progress.
Which brings us back to that fascinating contrast we discussed earlier. Anesthesia, solving the obvious agony, was adopted instantly, globally. Everyone got it.
Right.
But antisepsis, dealing with an invisible enemy, the microbes, and requiring surgeons to abandon the cherished laudable pusses theory, that met with 2 decades of resistance, inertia, skepticism, even when the data, like Lister's compound fracture survival rates jumping from maybe 54% survival to near 100%, was becoming clear.
That historical inertia, that reluctance to abandon a long-held belief or practice, even when evidence contradicts it, it's such a key theme in the history of medicine and maybe all science. It's crucial for understanding how new technologies and ideas ever get adopted or sometimes delayed.
So what does this all mean for us looking forward? We want to leave you, the listener, with this provocative thought to mull over. Given this clear historical precedent, the instant embrace of the obvious fix, pain relief, versus the slow, grudging acceptance of the conceptually challenging one, antisepsis, what future change, may be proven today by robust science or emerging technology, might modern medical professionals still be hesitant to fully embrace?
Yeah, what totally novel attitude, as the sources put it regarding Lister, might be required for the next massive leap forward in surgery or medicine? Are we perhaps clinging to some established dogma right now, something akin to laudable pus, that emerging science in fields like AI, robotics, nanotechnology, maybe genetic editing, is already starting to discredit?
What deeply ingrained assumptions might be blinding us to the next revolution?
The tools and the science for that next great revolution are probably, as they often are, already on the table or just coming into view. The big question is, which pioneers today possess the critical observation, the willingness to challenge the status quo, and the persistence needed to overcome the inevitable institutional inertia and write the next chapter of this incredible history?
Something to think about. Thank you for joining us for this deep dive into the revolutionary history of surgery.